Thank you very much. So, you've understood from this morning, there's no stopping us. There's no turning back. The population of people with a Fontan circulation is steadily increasing. It's going to double within the next 20 years. And if you open the internet, if you listen to some talks internationally, you're going to find again people who are pessimistic, said, oh, it's not going to work, going to have problems. And so don't listen to the no-goers. There's no stopping back. And the whole population of Fontan people en route, and we're going to go forward. And the reason for that is that, as Karen mentioned, almost half of the population is young adults, working, active, and they're here. We have to do something. We have to make sure that we do everything possible to give them a long-term future. And I feel inspired by one of my colleagues, Jack Rychik from Philadelphia, when I heard him saying that he wants this kid with a Fontan to live as long as himself and to have a life as good as his. And I think that should be our goal. It may be difficult, but that should be our goal. So what should we do? Well, right now, where we're at is we hypothesize, we do believe, and we've quoted, we even published that numbers, that there are between 50 and 70,000 people with a Fontan circulation throughout the world. These are not hard data. These are faraway guesses that we're extracting from actually the data from the Fontan registry. We look at the population we have, we transpose that in the population of North America and Europe, and that's the numbers we're coming up with. Right now, with these populations, the largest data set that we have is the one from North America, the Pediatric Heart Network study, which gather the data of people followed regularly in some of the major centers, and they start with 546 patients. At this stage, they have 373 patients left. We have the ANZ Fontan registry with around 1,400 patients alive with a Fontan circulation in the two countries. And then you have individual centers, people like Osaka, I like to quote them, they have 400 patients, they follow them up. The peculiarity is that they do every single examination on board you can dream of. So it's a rich data set, but very small number of patients. We need to find out what to do for the people with a Fontan, and all we're getting right now is a couple of trials, which are the way we can build up our knowledge to know which drug to use, for example. A couple, so vaguely 2 trials, which gather more than 15 patients, and these 2 trials are multicentric. They need several centers. So clearly, I think that we can do better. We can do better because there's a lot of issues, things we need to understand. Who should we do the Fontan? At what stage we should do it? Things have changed. We are not operating tricuspid atresia, you've heard that term, like 40 years ago. We're doing Norwoods, we're doing incredible things. Where do we put the barrier? And that is unclear now because the field has evolved. How do we treat them? Warfarin, aspirin, drugs for antihypertension. We have no clear idea. 45 years we've been doing that job, we still don't know. Anyway, how do we follow these patients? We don't even know. You know, we know that there are some issues, but we don't know how to look for them. And we'll talk more about that. We have concerns sometimes about psychology, neurodevelopmental outcomes. Are they doing well at school, at university? You've seen from Tim that a lot of them are doing very well. Thank you. But still, there's a real issue with quality of life that needs to be addressed, and it's likely that early intervention, as Rachel mentions, is the right thing to do. We still don't know how the Fontan circulation is failing. We know that some people die late after that or along the way, but we don't even know 45 years later. We still don't know how that happens. Is that the heart that is failing? It seems no. Is that the lungs? They're getting too stiff, the blood does not go through. Is that something else? Well, we still have no idea, which looks amazing, but that's where we stand. Indication for heart transplantation. Should we do it at the last minute? These guys are doing well for so long. Should we do it a bit earlier, a bit later? We don't know yet. And then we'd like to have extra solution because, as was mentioned, we're likely not going to have hearts for everybody, so we better have some artificial machines. So to solve all these issues, I thought that even though we have the largest database in the world in Australia and New Zealand, we need to expand our fields. And we needed to finally start an international collaboration. And so what I did is that I contacted the people who were, in my views, the biggest shot on earth. Either the guys who had the big ideas, or the people who had access to the largest data set of patients. And so we gathered a bit more than a year ago in Bordeaux. I thought it was a good idea because the first Fontan was done in Bordeaux, and I could attract a lot of these North American in good old Bordeaux as well. There was a good reason for them to visit. And so we met with Dr. Fontan in an evening in a winery. And so we had a lot of discussion for 2 days, and it was really an excellent brainstorming session about what the situation, what's the problem, what should we do. And so we have more and more people involved in the field. I'm not going to list all of them, but I can tell you, these are big shots, these are big guys, and there's a vibe of intense motivation in all these people. So we've met another 2 times since. So we've met in February in a meeting organized by the Hospital of Philadelphia, which is the biggest North American meeting in congenital heart disease. And we've met in Barcelona to the World Meeting in July. Our mission is to better understand the Fontan circulation, because if you want to improve things, we have to understand what's happening, and to improve treatment and long-term outcomes of all those who have undergone the Fontan circulation. So in the things that we want to do, first of all, we need to have a risk stratification for death and transplantation. And that's an example that is given for adults with heart disease, not for Fontan, but we need to say, okay, you were born that year, you had a Fontan at that age, you have predominantly, it's a single right ventricle, it's a single left ventricle, you have valve is like this and like that. Well, your expectation, you're going to be fine for 98% for the next 20 years. Don't come back and see me for a long time, or you're at risk for the next 5 years. We need to define who's at risk and with your profile to find out what are your expectations. That's what we want to do. And then we need to be a bit more refined at that. Right now, we're pretty good at seeing, characterizing you when you're fresh after Fontan, you're doing well and everything is fantastic. And then we can see when you're desperately sick and you're going to need a heart transplant or something. But the in-betweens, we have no idea. We're looking at patients as if they were just one of two, good or sick. And actually, it's likely that in between, you have an evolution, and we haven't we haven't characterized the evolution. So what we want to do is we want to do scoring of your Fontan status. From 1 to 10, we try to define where you're at. And to do that, likely, we're going to have to look at things like what kind of hearts do you have, what's your maximum exercise capacity, drugs like BNP, which are used to, it's a marker that is used in heart failure, whether you have rhythm problem, how is your end organs, your liver, your kidneys, and then we can define where you're at in the curve. And the beauty of doing that scoring, it's not to know if you're good or not, 1 to 10, it's not another way of scoring. But what is important for us in scoring you is, if we do an intervention, we try new drugs, we don't have to wait 20 years to find out if people die more or less from it. We could see if your scoring improve with that. And so that would be a more refined way to adjust and analyze new intervention. So right now we have small projects. We want to have this community existing, so we'd like to look at AV valve replacement. So you all know that the valve inside your heart, between the pumping chamber and the collecting chamber, is very important. In the Fontan circulation, this valve can fail more than in normal hearts. And unfortunately, we can repair valves that are failing, that are leaking, but in Fontan, it's more complicated. With a single ventricle, these valves are more difficult to repair, and so it's not working as well. Right now, what's happening is that if you have a valve that is failing a little bit, the chances are the doctors will look at you and say, we're going to look at it, and they're not going to do much. We've looked at our numbers, we're not reoperating, because we don't have very good solutions, And we haven't proven that by doing an extra operation, you're going to bring a benefit. So there's uncertainty, and we don't know that we have a good solution for that. So looking at the effect of replacing with an artificial valve is something that may be of benefit, because maybe that's the solution. And the people have, we have less than 10 in the Fontan registry. Boston has got 7. The Pediatric Heart Network has got probably 30. So we want to put all the data together and see what's happening. So Dominica you'll hear talking during the day, will lead a project looking at pregnancy. So we know that it's possible to have a pregnancy when you have a Fontan. Not an easy thing, but we'll discuss about it. It's not impossible. But is that good or bad for you? I mean, if you have congenital heart disease other than a single ventricle, having a pregnancy is a strain on your heart. And so we don't know exactly the impact on that. We have 23 patients that we can compare to other 23 females in Australia and New Zealand, but we would need like 150, 200 to find out whether years after pregnancy, the pregnancy has an impact on the heart of those with the Fontan circulation. We're going to start some collaborative trials for medical therapy. We need to find out this new generation of drugs that we use for dilating the vessels in the lungs, whether it has an impact on the Fontan circulation. The drugs that we've been using, and lots of people here are probably on these drugs, are usually used for decreasing the blood pressure. We need to find out whether it has any use in the Fontan circulation. What do we have to do when you have a fast heart rate? And the things that we have agreed on, we're going to need to build an international registry. We need really large sets of data to find out what to do. And now is the time to do it, because we need to build up cohort, people taking this type of drug and follow them for 10, 20 years to find out. We should have started that 40 years ago, but we didn't know we would be here today in such a good situation. But as my son said, the best time to plant a tree was 10 years ago. The second best time to plant a tree is today. So we can organize another meeting, but we don't want to be another meeting. There's an enormous load of scientific meetings. But what we want to do is we want to build up a meeting with all the experts in the field, involving parents' communities, where we think about the project not when they finish and presenting it. We want to gather the people before we starting the project, share ideas. What do you think of that? I want to start that. There's no point. I've done half of the work. Okay, I'm not going to do that. And so we're going to share the ideas and say, if somebody has got a good idea, well, I could bring you this, and gather forces together. If we want to succeed in this undertaking, we need everybody, and we need doctors, but we need to work hand in hand with patients' community, and we've demonstrated that by working in close relationship with you, we can achieve a lot more. And we need industry as well. We need them to be interested. We need new drugs, and we need the money as well. So it has to be a partnership between the three poles. One of us alone can do anything. We all have to work together on this. And I'm very fond of this. Some of you may have seen that slide before. John Fitzgerald Kennedy, who was assassinated actually a month after I was born, but he used to say that, ask not what your country can do for you, ask what you can do for your country. It's the same for the Fontan circulation. You shouldn't ask yourself what your Fontan can do for you. And what the people have said, the doctors have said, oh, it's terrible, these Fontan, they have lots of problems, there's nothing we can do about it, and so on, they're all going to be terrible. But at the end of the day, us doctors, did we do the right job, Yes, there's a lot of problem coming, but we should provide the things that are necessary to have a good Fontan circulation. We should first start working to have patients with large pulmonary arteries, with valves that are not leaking, and with good heart function. And then we look at this patient and see what's happening. But we should first do the job, all what we can do, because we can still do progress in that, and then we'll see what happens. And if you have a Fontan, if you're not working towards it, then you're not doing your job. Today, if you have a Fontan circulation, and you're not exercising, for example, and I'm not talking a little bit of exercise, I'm talking about a grueling 1.5 hour, 3 times a week of exercise. I think that's what is absolutely needed for you to keep a good Fontan circulation, and it seems like it's likely the most important things, not the type of heart you have, not whether you have this or that or any kind of characteristics, but if you have a high level of physical activity, it seems like you're going to be better. Your survival is better, so you have higher chance of living, and you have a better chance of living in good conditions 15, 20 years later. That's the data that is coming out. So you have to work on your Fontan more than anybody else in the room. And today, if you're the mother or a father of a kid with a Fontan, or if you have a Fontan circulation yourself, and you're not participating to some research, some study, and you're not raising from your Fontan, you are not doing your work. You have to work as well. You are responsible for what's happening. Don't think that it's going to be given to you. You have to be part of the work. And so I'll just give you a brief update of the things you can do. In very brief words, you'll see a stand outside. We're trying to have Medicare linkage. We had a bit of resistance for the people to agree, give their authorizations to get the data, their own data from Medicare. It seems like it's like we're asking people to get into their bank account. It's not the same thing. And I'm going to briefly explain you what we get from that. Yes, it's important for us to know how much your care is costing. The only way we can leverage funding for the research is by saying, hey, this guy is so costly. It costs a bloody fortune. We can cut the costs by doing good research that will make them feel better, live longer, and they're going to cost less if they're better taken care of. So we need this data, absolutely mandatory. But the other thing is to know, all we know about you mainly is your cardiac history, but we know that there's a lot of other issues. There's psychological development, there's a gastroenterological development, there's a lot of different issues. Let me make a guess. We know that the heart and the lungs of people with Fontan circulation is an issue, and that's the main point of cost. Do you know what is the second point of cost? Apart. So it's the most important thing, and we've seen that in Australia and New Zealand, and we've seen it in a recent paper from last month in a Mayo Clinic. Exactly same number. What is the higher cost beside the heart? Anybody? Lee, no, but Lee cannot talk. Yes?
Dental.
Sorry? Dental. How did you know? But dental care, I mean, that came as a surprise for me. You talk to the dentist, and they say, of course, this guy have lots of problems, and there's issues. There may be issues because the flora is different in the patients with the Fontan circulation, because the immunity is different. We're finding out it may be some bad sugar a bit, but likely not. It's something else. But it can be solved. The guy when I talk to the head of dentistry in my hospital, they say, bring us the kid at 2 years of age, and we'll solve that issue. So it's not a question of finding out how much it costs. It's a question, what is your health? And that's an indirect way we can identify the problem and work on the problem. If you don't know about the problem, there's no way we can work on it. Medicare linkage, all of you who have not participated. Functional outcomes, as Karen has said, we've done a large work on cardiac exercise, MRI, bone density. There's still a few spots for those who are living in New South Wales and New Zealand to get there before December. Quality of life, we've asked the people to fill in this survey. It's also very important. Beside cost, what is important for the health institution is quality of life. They're waiting the results of what we're doing, not only in money, but in years life. So they calculate the mix of the number of years you're living plus the quality of life. We need to know this number. There's going to be a trial with the industry starting in the next 2-3 months. The first trial is the Rebuttal Trial, and it's advertised, has been started in one center in North America now, so we can start talking about it, I believe. It's a trial on pulmonary vasodilator. So these are drugs that have been used for high pressure in the lung, pulmonary hypertension. If you have high pressure in the lung, you have drugs that can open your lung arteries. And Fontan, the blood goes passively through the lungs. So there's some evidence that the vessel in the Fontan circulation, because there's not the pulsation, probably, of the heart beating into this circulation, that the vessels remain smaller and constricted. We don't know if that happens to everybody and in what amounts, but it does happen. We know it happens. So we've seen it by having this drug dilating it, your cardiac output, your overall situation is better. These trials are now looking at 1 year. What we need to know is whether maybe having that for your whole life may be of interest. It's the best promising drug that we have now. And so please, I invite you, discuss with your cardiologist to see if you're a candidate and participate. It's important for a few reasons. It's important because it may be good for you, so it may be a best chance for you to be better, and not only you, but all the other ones around you to be better. It's important because it brings money to the registry, to all those who participate, and not only on this trial, but we are not a very good platform in Australia for trials. Some places in the world are very good. Don't ask me, but Spain is very good, and so there's some places that are very good. This is a good opportunity for our community to show what we can do. If we can show that we're good for trials, that's not going to be the last one. That's going to be the first one, but we're going to have a lot more. And that means you'll have access to two more. We want to check, that's very original, we're going to see with these drugs that we take for high blood pressure. In Australia, 35%, so a bit more than a third of you are on these drugs. And for 2/3 of these people, well, the reason why we put you on this drug is because we think it might be better. If you look at the science, the whole science saying the same is that it has absolutely no interest. But the people say it looks better. We're not doing too badly. If you look at some centers in North America, 60% of them are on these drugs for no good reason. So it may be important, it may be not important, and yes, we've done it for 45 years and we still don't know whether it's good or not to be on these drugs. So we've decided to try a new design. So we're going to take the people who have no good reason to be on these drugs, and we're going to stop the treatment. And so instead of doing a trial where we try something else, we're going to try to stop it, to see if there's any difference. And we monitor closely everything. And so we'll ask you to participate. I'll talk about the other one. And then the last one is we're looking for super Fontan. From the results from the functional study that we've been doing, it seems like, okay, your exercise capacity as Fontan people are a bit lower than normal, normally 2/3 as an average than normal. But there's some guys who have more than 80% of normal, who are practically normal. And that's not too bad. It was, I think, 9% when we look at it. The whole question today is to know, we know that when you have a Fontan circulation, your circulation may have a degradation with time. But is that in everybody? Everybody has looked at the whole package. And we know that some people are, disadvantaged. And they take everybody. Is this Fontan circulation always doomed to go down? Or can it last forever in some people? And so there are some people who are doing very well. The question is that if we find out that we can maintain this Fontan circulation working well for decades, and I'm talking 30, 40, 50 years, then we can work on all the other ones to bring them to that. But we haven't answered to that question fundamentally. Can the Fontan circulation last for 50, 60, 70 years? And looking at the best of the lot is interesting. So if you think that you're a superhero, you're super fit, and you're really good, if you know somebody who's super fit and you haven't participated, we have captured all the ones who have been in a functional outcome study, so we have exercised them, but if you haven't been on an exercise bike in a recent time, please show off what you can do and get to us, we'll exercise you and we'll see whether we can have data from here. Thank you very much.